आप मुझे बस ग्रीन सिग्नल दे दो, मैं स्टार्ट कर दूंगी। ठीक है सर। So hello everyone. Today we would be discussing one of the most important topic of NCLEX examination, that is fluid and electrolytes. So I am Anjali and I am a RN from India. So let's get started. So before we start with the topic, first of all, we'll understand the baseline data about the fluid distribution in a body. So total fluid, body fluid is around, if we talk about males, like lean body weight males, it's a total body fluid is 60% of total body weight. And if we talk about females, it's around 50% of total body weight. So this total body fluid is further divided into two subheadings, that is intracellular fluid and extracellular fluid. If we talk about intracellular fluid, it occupies around 60% of total body fluid, which we can say like 2/3 of total body fluid, and this extracellular fluid carries 40% of total body fluid, which is around 1/3. So this intracellular fluid, as the name is depicting, intracellular means inside the cell, that is around 60%, and this is enclosed by cell membranes. And this extracellular fluid, that is 40%, this is outside the cell. So outside the cell there are tissues also, vessels also. So this extracellular fluid is further divided, that is interstitial fluid and intravascular fluid. This interstitial fluid, in see, if ECF is around, this extracellular fluid is around 100%, so it's further interstitial fluid, that is interstitial fluid, that is around 75% of total extracellular fluid. Okay, and intravascular, that is around 25%. This interstitial is like around the tissues, and this intravascular, as the name is saying, between and around the vessels. So this intravascular, there is presence of plasma and red blood cells. So this is basically the fluid distribution in a human body. So to wind it up, I would say there are two type of total body fluid, that is intracellular and extracellular. Intracellular holds the major space, that is 60%, and extracellular has 40%. Extracellular is further subdivided in interstitial and intravascular. So distribution in the body determines distribution of intravenous fluid. Okay, so distribution of fluid determines the distribution. This is a very simple line, that distribution of body fluid will determine the distribution of intravenous fluids. So now, as we have discussed, we would be discussing with the help of diagram, that is fluid compartments in the body. First is intracellular, that is inside the cell. So this is a cell, and inside there is intracellular compartment, and extracellular is fluid found outside of cells. And as we say, there was interstitial fluid, this one, see, interstitial around the tissues, and plasma is the fluid component of blood. So this is intravasculars. Okay, these are the vessels. Inside the vessels there are intravascular, and inside this intravascular fluid there is presence of plasma and red blood cells. So this is another diagram, same only. See, this is cells, and inside the cell there is intracellular fluid, and this is interstitial fluid, that is around and inside the tissues, and this is extracellular fluid, intravascular space, which contains plasma. So we will further discuss few basic terms that is required for this understanding of this topic, that is fluid and electrolyte. So we will quickly discuss. First of all, we need to understand what is osmosis, that we all are familiar with this term, that is osmosis. Osmosis is actually, in simple terms, I would say it is the movement of solvent. Movement of solvent. Okay, solvent is like water, any fluid that is solvent, and solute is particles, or we can say some elements present inside the solvent, that is solute. So, movement of solvent, for example, water, from lower concentration to higher concentration. And there is one specific character of osmosis, that this movement takes place only in the presence of semi-permeable membrane. So in simple terms, if we say osmosis is movement of solvent from lower concentration to higher concentration through the semi-permeable membrane. So, first we will say what is osmotic pressure, created by the concentration of ions, electrolytes in each compartment. Okay, so the pressure that is created by the solutes that we have discussed, ions and electrolytes in each compartment, and this osmotic pressure is responsible for containing water in each space and keeps volume constant. So this this pressure keeps the volume constant throughout the vessels and cells. So this is very important, that is osmotic pressure. Next is osmolality. Osmolality is number of particles per kilogram of water. So for example, there is 1 kilogram of water, that is solvent, and the number of particles, that can be ions and electrolytes, that are present in 1 kilogram of water, that is known as osmolality. And if we discuss the plasma osmolality, it's around, normal value is around 280 to 300 milliosmol per kg. That means in 1 kg of water, roughly 280 to 300 milliosmols of ions or electrolytes are present. Okay, now is osmotic equilibrium, that is water moves, that I have already discussed with you guys, that is water moves across the cell membrane that should be semi-permeable, from region of low osmolality to one of the higher osmolality. So I believe these all terms are clear. That would be important in upcoming slides. Okay, we have discussed what is osmolality, and then osmotic pressure, osmotic equilibrium, that is same only. The movement of water and solvent from cell membrane, from region of low osmolality to the higher osmolality. And osmolality, we have said that number of particles per kilogram of water. So moving further, now we would be heading towards our main topic, that is types of IV fluids. So this is quite important topic, so I request you to please be concentrated. So first, we need to understand, as there are basically three type of IV fluids. First is isotonic, next is hypotonic, and the last one is hypertonic. So basically three type of fluids are present. Okay, so to understand this nicely, first we will discuss about isotonic fluid, whose osmolality is 250 to 375 per liter. Okay, so this is the osmolality of isotonic fluid. So this type of IV fluids, this criteria is based on osmolality of fluid. Osmolality of fluid, and this isotonic fluid have 250 to 375. This is very important to understand. Okay, I'm sorry. I'll write it again. 250 to 375. Okay, this you need to learn to understand the concept. So isotonic is 250 to 375, right? So isotonic means the concentration of solute to the solvent is same. Okay, the osmotic concentration is same, and the fluid would not shift from intracellular fluid. I mean, there would be no shifting of fluid. Okay, no shifting of fluid from intracellular to extracellular. So this intracellular or interstitial fluid, if it's isotonic, there would be no fluid shifting. So this is, and the examples for the same will be discussed in upcoming slides. And then if we talk about hypotonic means, hypo word is less. Okay, hypo means less, so there would be less osmotic concentration. That is the basic we have learned, 250 to 375 per liter. That is for isotonic. So in hypotonic, there is concentration is less than 275 per liter, and there is movement of fluid from extracellular fluid to intracellular fluid. All right, so in hypotonic there would be movement of fluid. Then if we talk about hypertonic, hyper means more. So there would be more osmotic concentration, that is more than 375 per liter, and there would be movement of fluid from intracellular fluid to extracellular fluid. Okay, so I believe this concept is clear. So we'll be discussing its examples in upcoming slides. Now a quick review. Isotonic fluid has same tonicity as intracellular fluid. Okay, so which is why there is no shifting of fluid. See, no fluid shifts. And the example of isotonic fluid is NS, that is normal saline, LR, that is lactate ringer, and D5W, dextrose 5% in water. So these all are the example of isotonic, and it needs to be remembered. Now this used for fluid and electrolyte replacement. This is very important fluid, and it is used for fluid and electrolyte replacement. Then if the person is having isotonic fluid infusion, we need to watch for fluid overload, edema, and diluted lab values. We need to be very keen about the lab values. Now if we talk about hypotonic, there is less solutes than intracellular fluid, and if you remember, the osmolality of this fluid was less than 275 per liter of fluid. Then there is less solute, and example is 0.45% NS. I forgot to mention, this NS is 0.9% NS. Okay, so this hypotonic is 0.45% NS, 2.5% D5 in water, and 0.33% NS. So these all are the example of hypotonic, and there is fluid shift into the cells, that is from extracellular fluid to intracellular fluid. There would be movement of fluid into the cells. Need to remember this. In hypotonic, fluid will go into the cells. Then we need to watch for decreased BP, as extracellular compartment is fluid is going inside the cell. So there would be decreased BP, we can say, related to decreased blood volume. Okay, and it should not be given in the patients with low BP, because already the BP is low, and if we are giving hypotonic solutions, the BP would get deteriorated. as there is fluid shift from extracellular compartment. In increased ICP, we won't give in stroke patient, neuro patients, liver disease, trauma, surgery and burns. Then if we talk about hypertonic, the osmolality of this solution was more than 350, sorry, more than 375. And if we talk about the example, it's D5 half D5 and D5 in NS in D5 in 0.9% NS, and then D5 in ringer lactate. These all are hypertonic, and another example we can take is 3% NS. And the fluid shift out of the cell. In hypertonic, we discussed fluid is shifting into the cells, and in this fluid is shifting out of cells. And the indications for using this hypertonic fluid is hypovolemia, vascular expansion, increased urine output. Like in post-op patients, we would be using this to increase the urine output. Then if third spacing is there, and diabetic ketoacidosis. Then if the patient is having this hypertonic fluid, we will keenly watch for hypervolemia, because there is a risk of intravascular fluid overload. Then increased NaCl and extravasation, cellular dehydration, hyperglycemia. These all we need to assess if the patient is having hypertonic solution infusion. Then we should not give this fluid to the patient with renal or cardiac patients because of edema. I mean, there is intravascular risk of intravascular fluid buildup. So we would not be giving this fluid to, especially to the cardiac patients and renal patients, because they are already at risk of fluid overload. Then to the patients with dehydration. So this has been explained with another example. In hypertonic, as we have discussed, fluid will move from intracellular fluid to extracellular, means the fluid will move from inside of the cell to outside of the cell, like it's given in this. So means the normal cell will shrink in hypertonic. All right, see, hypertonic have greater concentration of solutes than plasma. Then isotonic, in which they have same solute concentration, there would be no fluid shifting, and if there is fluid shifting, there would be counterbalance. Okay, then hypertonic, they have lesser concentration of solute, and there would be movement of solvent from extracellular fluid to intracellular fluid. That means cell will swell. Okay, so in hypertonic, cell will swell, and in hypertonic, cell will shrink. All right. So another classification we can say is that crystalloids and colloids. Crystalloids are like normal saline Ringer lactate solution, that is also known as Hartmann solution. Then 5% dextrose. These all are the example of crystalloids. And if we talk about colloids, the example of colloids are human albumin, gelatin solution like hemosil and gelafendin. These are very rarely used in clinical setup. Then dextran, this is also not used these days. And then is hydroxyethyl starches, that is heta starch, that is also not much used these days. Mainly crystalloid solutions are being used. The reason is they have less side effects. First reason is that, and another is it's quite cost effective, and they are small molecules and easy to use, and they provide actually immediate fluid resuscitation. These crystalloids provide immediate fluid resuscitation. All right, immediate resuscitation of fluid, resuscitation. But there is one risk, that these crystalloids may increase edema. And if we talk about colloids, they are larger molecules, unlike crystalloids, which were small molecules, and they have more cost. It's costly, and then they may provide swifter volume expansion but may include allergic reactions. There was a risk of in crystalloid there is a risk of increased edema, and in this, if we talk about side effect, there is a risk of there is a risk of allergic reactions, and like kidney failure and blood clotting disorders. These all are the risk of giving crystalloids: kidney disorders and blood clotting disorders. All right. So commonly used IV crystalloids in clinical setup is normal saline, lactated ringer, normosol R, and it contains water, sodium, chloride, and additional electrolytes. And advantages is there is low risk of adverse reaction, and if we talk about disadvantages, it freely distributes across vascular barriers, and there is risk of hypernatremia and hypercholoremic metabolic acidosis. So if we are using this, there is if we talk, there is very less, but there is risk of hypernatremia and hyperchloremic metabolic acidosis. Then we can talk about acute fluid resuscitation. What is this fluid resuscitation? I mean, fluid resuscitation is required in the case of shock. Like patient gets into the shock that is associated with reduced cardiac function and organ hyperperfusion. Okay, whenever the patient have shock, their organs are in hyperperfusion stage, and the cardiac function has also been decreased, and the sign and symptoms usually occur when around 15%, that is 750 ml of blood volume is lost or shift out of intravascular space. So when around 15% of body volume is lost or shift out of, like there is loss of fluid from intravascular space, that is around 15%, then only the symptoms of shock appears and acute fluid resuscitation is required. So if we talk about the sign and symptoms of intravascular volume depletion, that is tachycardia, hypotension. There is hypotension due to fluid loss from intravascular space, due to which the body will have a compensatory mechanism as increased heart rate, that is tachycardia. Then there would be orthostatic changes in heart rate and BP, increased blood urea nitrogen to serum creatinine ratio, that is more than 10 to 1%. This is important. Okay, so all as the patient will have dehydration, so there would be dry mucous membrane, decreased skin turgor, reduced urine output as the patient is in shock, and all the organs have hyperperfusion, and there would be reduced urine output, and the patient will have the cerebral perfusion will also reduce, so patient will be having dizziness. So improvement after 500 to 1000 ml fluid bolus. So whenever the patient is in shock, we need to rapidly infuse this fluid. We usually give patient isotonic fluid in that time. So after instilling around bolus fluid of 500 to 1000 ml, there would be improvement in the patient, and fluid resuscitation is indicated in patient exhibiting sign and symptoms of shock. So fluid this was about like acute fluid resuscitation, but sometimes maintenance fluid replacement is also required, like in patients. First we have resuscitated the patient, now we need to keep the maintenance fluid mainly in the patients who are unable to tolerate oral fluids. So the main if we talk about the goal of this maintenance fluid is to prevent dehydration and maintain normal fluid and electrolyte balance in the adult body. So this maintenance fluid is administered as continuous infusions through peripheral or central lines. So maintenance fluid would be given as a continuous infusion depending upon the patient's disease condition and demand of the body. The rate of infusion is set and it is given as a continuous infusion through peripheral or central lines. Example of maintenance fluid is D5W with 0.45% NaCl with 20 to 40 milliequivalents of potassium chloride per liter. So this maintenance fluid is designed in a manner that there should be maintenance of fluid and electrolyte inside the body. So we would be giving dextrose along with sodium and chloride, and also the most important electrolyte, that is potassium and chloride. Potassium is the most abundant intracellular electrolyte. So we would be giving this so that the dehydration can be prevented and the fluid and electrolyte balance should be normalized. So we would be giving this as a maintenance fluid. So there is basic calculation that is required. So calculation to determine daily volume needed in children and adults. So first we will say for this children, and then we will discuss for adults. So for children, for first 10 kgs of weight, we will be giving 100 ml per kg for first 10 kgs of weight. Then 50 ml per kg for next 10 to 20 kgs of weight. Okay, then plus 20 ml per kg for greater than 20 kgs. Okay, so this is 100 ml per kg for 10 kgs of weight, then 50 ml per kg for 10 to 20 kg weight, then plus 20 ml per kg for more than 20 kg of weight. All right, so for example, this would be I will explain with example. That is, for example, we have a child who is 20 kgs. All right, so first for 10 kg we would be giving him 100 ml per kg. Okay, 100 into 20. Then for next 10 kg we will be giving him 50 ml per kg. That would be 50 into 10. So this would be the total, we will add this, and this would be the total fluid that needs to be given to the child. All right. So next is for adults. For adults we would give 10, 20 to 40 ml per kg per day. So this is for adults. That was for children, and if we talk about adults, that would be 20 to 40 ml per kg per day for adults. Adjust fluid according to the individual's patient's input, output, and insensible fluid losses. All right. So if we talk about electrolyte composition, one second. Before discussing this electrolyte composition, I would discuss this concentration of electrolytes. I mean, the concentration of these electrolytes present in this fluid. Okay, so I would be using this space. So I would be discussing about common fluids. First of all, we will write here, these are the headings, that is fluid, then osmolality of the fluid, then sodium, chloride, potassium, calcium, magnesium, bicarbs, and another is lactate. All right. So first of all, we'll discuss about plasma. The osmolality of plasma is around 280 to 290. 280 to 290. and the sodium present in plasma is 135 to 145 milliequivalents, and chloride is 96 to 106. Potassium is 3.5 to 5.1. In some literatures it is written as 5.2, so you can consider any 5.1 or 5.2. And calcium is 4.4 to 5.2. If we talk about magnesium, it is 1.8 to 2.4, and bicarb is 22 to 26, and lactate is 1. So this is the normal plasma concentration of these electrolytes. Alright, so first we will discuss about normal saline. That is one of the isotonic fluid. The osmolality of normal saline is 308, and the sodium present is 154. Chloride is also 154. There is no potassium, no calcium, no magnesium, no bicarbs, and no lactate. So this is about sodium, normal saline. And now if we talk about lactated ranger, that is Hartmann solution, the osmolality is 273, then sodium is 130, chloride is 109, potassium is 4, calcium is 3, there is no magnesium, no bicarbs, but there is lactate, that is around 28. I'm so sorry. Lactate is around 28. All right. So next, so these two are isotonic fluids. Isotonic fluids. You can make notes of this if you want. I'll wait. Then we can discuss one example of hypertonic and hypotonic. Okay. For hypotonic, we would be taking 3% NS as an example, and for hypotonic, we can take half NS, that is 0.45% normal saline. All right. So this was for plasma. For hypotonic, we will take 3% NS. The osmolality of 3% NS is around 1030, that is 1030, as it is a hypertonic solution. All right, so the concentration of sodium, just give me a second. So the concentration of sodium, there is no I mean this sodium chloride, the sodium and all, there is high concentration of sodium and the osmolality is around 1030. So there is I mean not clearly mentioned in literature regarding this concentration. So we just need to remember the osmolality of this 3% NS. All right. So next is we will discuss, this is hypertonic, example of hypertonic solution. Next we can discuss about half NS, that is 0.45% of normal saline. The this osmolality is around 154. Sodium is 77. Chloride is also 77. Then there is no potassium, chloride, magnesium, bicarbs or lactate. So this is basic about common fluids and you need to remember all these. All right, and now we can move ahead for electrolytes. All right, you can make a note out of this. So I believe you have noted this down. So now we can move ahead for electrolytes. So first we would be discussing the electrolytes composition. All right. So the basic electrolytes are sodium, potassium, chlorides, bicarbs, calcium, magnesium, and phosphate. All right. So uh, this intracellular fluid and extracellular fluid divided into two, that is plasma and interstitial fluid. So the concentration of sodium present in intracellular fluid is around 10 millimoles per liter, but if we talk about plasma, in plasma it's around 140 millimole per liter, and in interstitial space that is 145 millimoles per liter. And if we talk about potassium, in potassium there is in this is the most abundant intracellular cation, that is potassium, most abundant intracellular cation, abundant intracellular cation. All right, the concentration is 155 millimoles per liter, and in extracellular it is 3.7 and 3.8. If we talk about chlorides, chloride is 3 millimoles in intracellular fluid, and in extracellular fluid this is 1 or 2. So chloride is most abundant extracellular fluid cation. Like potassium was intracellular, chloride is extracellular, and in interstitial space there is 115. Then bicarbs in interstitial it's 10, in extracellular plasma it's 28, and interstitial fluid it's 30. If we talk about calcium, that is ionized, in intracellular that's very less, that is less than 0.01 millimoles, and in plasma it's 1.2, and interstitial also 1.2. And then magnesium it's 10 in intracellular, in plasma it's around zero point 0.8, and interstitial also zero point 0.8. Then in this phosphate is present in good amount in intracellular fluid, that is 105, and in plasma 1.1, and interstitial 1.0. So this is the basic composition of electrolytes that you need to remember. Now we would be discussing about these basic these electrolytes. First of all, we would be discussing about sodium. All right. So the normal concentration of sodium inside the body is around 135 to 145 milliequivalent per liter. All right. So the normal sodium concentration is 135 to 145 milliequivalents per liter. Now the role of sodium inside the body is uh, role is sodium in extracellular fluid determines the tonicity of extracellular fluid. So the amount of sodium present in extracellular fluid, it actually determines the tonicity of extracellular fluid, and it directly affects the distribution of water between extracellular and intracellular compartments. All right. So the sodium is one of the important electrolyte inside the body. So first it determines the tonicity of extracellular fluid, and another is it directly affects the it directly affects the distribution of water between intracellular and extracellular compartments. So next is we will discuss about hyponatremia, that is sodium concentration less than 135 milliequivalent per liter. So we would be uh, discussing with the help of this chart. uh, this is hyponatremia, as the name is depicting, that is hyponatremia. So the lower concentration of sodium inside the body. So if we discuss about definition, it is low serum sodium concentration, that is less than 135 milliequivalents per liter, and is hypotonic. True hyponatremia, also low serum osmolality. First, slow there would be serum sodium concentration would be low, and then serum osmolality will also be low, that is less than 280 milliosmoles per kg water. So and the onset of this hyponatremia is acute, that is less than 48 hours, and chronic if it is more than 48 hours or duration unknown. So this hyponatremia is basically two types, that is acute and chronic. All right, so acute is less than when it occurs in less than 48 hours, and if we talk about chronic, it is more than 48 hours, occurrence is more than 48 hours. Etiology behind this hyponatremia is hypovolemia. For example, in renal, dermal or gastrointestinal losses, or there is some third spacing of fluid, or there is some hemorrhage. This is hypovolemic hyponatremia. Then euvolemic is in which the concentration is, I mean the concentration of solute and solvent is equal. For example, in SIADH, that is syndrome of inappropriate antidiuretic hormone, then low salt intake and water intoxication. In all these conditions, there would be the euvolemic hyponatremia. Then hypervolemic in, for example, in renal failure with oliguria and congestive heart failure. So we have discussed the type of hyponatremia, then etiology, that is hypovolemic, euvolemic and hypervolemic hyponatremia. That is hyponatremia is lesser concentration of serum sodium. Then diagnostic, how we can evaluate this with the help of serum sodium and osmolality. Then further serum urine studies to identify etiology. Then treatment, before discussing the treatment, we would be discussing the symptoms. Uh, Severe symptoms, then mild to moderate symptoms. Mild to moderate symptoms of low sodium includes headache, dizziness, forgetfulness and malaise. The patient will be very much like uh, very much drowsy, and he will be having headache and malaise. Then there would be presence of nausea and vomiting. But in case of severe symptoms, that is usually with acute, that occurs in like in short span of time, in less than 48 hours, there would be stupor and sometimes coma. Patient may develop seizures, there would be ataxia, and respiratory failures may be there. This is these are the, I mean severe symptoms of hyponatremia. And if we talk about this severity, it actually correlate with the um, one second. So the severity of this actually depends upon, like it is depending upon the degree of cerebral edema. All right, and in severe symptoms there would be muscle weakness. The patient will complain about muscle weakness. All right, so this these are the symptoms of hyponatremia. And signs of volume status in hypovolemia. I mean, if we talk about volume, fluid volume. So in case of hypovolemia, there would be dry mucous membrane, and orthostatic hypotension would be there, and oliguria would be there, that is decreased urine output. Then the orthostatic hypotension is postural, I mean when the patient will change posture, there would be decreased blood pressure. And if we talk about hypervolemia, there would be ascites, that is generalized edema. Generalized edema is anasarca, I'm sorry, anasarca. Ascites is in this peritoneal cavity, collection of fluid in peritoneal cavity. Then there would be effusions, like pleural effusion would be there. Then peripheral edema will be present. These would be in the case of hypervolemia. So these are the symptoms, mild and moderate. In this I have used one term, ataxia, that is ataxia is impaired coordination. Okay, ataxia is impaired coordination. Impaired coordination. or balance, we can say. All right. Uh, Moving towards the treatment of hyponatremia, in case of acute or severe symptoms, we need to correct the sodium quickly with hypertonic saline, that is 3% NS, then treat underlying cause. All right. So the sodium would be treated with hypertonic saline, and then we will treat the underlying cause. First of all, we need to treat hyponatremia, then we will treat the underlying cause. Then if there is chronic without severe symptom, we need to correct sodium slowly, like cause specific treatment we can do. All right. If it is acute, like onset is within 48 hours, we need to correct it quickly, as with 3% NS, like hypotonic saline. But if then we will treat the underlying cause. But if it is chronic, we need to correct it slowly, like we can treat the cause, like cause specific treatment is given in chronic hyponatremia. Then complication is secondary to hyponatremia. All right. The complications are secondary to hyperanemia, for hypernatremia. For example, cerebral edema. And treatment associated complications can be osmotic demyelination syndrome. This demyelination syndrome occurs when we infuse 3% normal saline very rapidly. That time there may be demyelination. All right. So, if we move towards type of hyponatremia, there is hypovolemic hypotonic hyponatremia, then euvolemic hypotonic hyponatremia, and another is hypervolemic hypotonic hyponatremia. All right. So, these are three major types of hyponatremia. First, we have discussed, that is uh, acute and chronic. Now it would be hypovolemic hypotonic hyponatremia, euvolemic hypotonic, and hypervolemic hypotonic. All right. So definition of hypovolemic hypotonic hyponatremia is deficit of both sodium and fluid, but total sodium is decreased more than total body weight. All right. So there would be deficit, I mean hypovolemic is like fluid is also lost, hypotonic hyponatremia is sodium is also lost, but total sodium is decreased more than total body weight. All right. But if we talk about euvolemic, there would be euvolemic is body fluid is not lost, so normal total body sodium with excess fluid volume. All right. So, this is like dilutional hyponatremia. Got it? Normal total body sodium with excess fluid volume. So, the sodium would be, total body sodium would be all right. Like in hypovolemic hypotonic, there was decreased total sodium. But in this, total body sodium is all right, but there would be excess fluid volume. So, there would be dilutional hyponatremia. All right. So, and then this hypervolemic hypotonic hyponatremia, it would be caused by excess sodium as and fluid. Okay. So there would be excess of hypervolemic, means more of fluid. There would be excess of total sodium and fluid, but fluid excess predominates. All right. So there is excess of both sodium and water, but fluid volume predominates. All right. So example of this type of hyponatremia is fluid loss, third spacing, and renal loss. And example of this euvolemic is, it happens in SIADH, that is syndrome of inappropriate antidiuretic hormone. Then some medications, and this happens in heart failure, cirrhosis, nephrotic syndrome. And if we talk about treatment, the only treatment for this hypovolemic is fluid resuscitation, as there is loss of both fluid and sodium, so fluid resuscitation is required. Then in euvolemic, we need to treat cause, fluid resuscitation, vasopressin receptor antagonist we will give. Then in hypervolemic, sodium and water resuscitation, and we need to treat underlying cause. Vasopressin and receptor antagonist are also given. Alright, so in this, as there is excess of sodium and water, so we will do restriction of sodium and water. Now, there are some principles of hyponatremia correction that are very important and needs to be followed in practical clinical settings, that avoid overly rapid increase in serum sodium, that is more than 10 to 12 milliequivalent per liter in 24 hours. Usually it is recommended to treat around 10 milliequivalents per liter in 24 hours. All right, we should not correct sodium rapidly, and we also need to treat underlying cause. Chronicity of hyponatremia impacts the rate at which correction should be undertaken. As I have already mentioned in the previous slide, if it is acute, we need to treat it a bit rapidly, but if it is chronic, we need to treat it slowly, and it is actually cause specific treatment. All right, then transient or permanent brain dysfunction may result from overly rapid correction of hyponatremia, that we called osmotic demyelination syndrome. All right, so this is very important, and whenever the sodium is corrected, we need to keep all these important principles in mind. Now this 3% sodium chloride is used in treating this hyponatremia, which is high alert medication, and it should be given very wisely. So this is known as high alert medication. The administration of 3% NS is used in symptomatic hyponatremia. For example, there is presence of few symptoms like patient is dizzy, confused, or they are having severe muscle weakness. That time we will treat this with this 3% NS. We will infuse at the rate of 1 to 2 ml per kg per hour, not more than this, otherwise it can cause demyelination. All right, central IV access osmolarity more than 900 milliosmol per liter, and if peripheral line is used, like in emergency, we need to monitor for phlebitis. This 3% is hypertonic. All right, like osmolality is more, so we need to give this peripheral this if we are using the peripheral line, we need to monitor the patient for phlebitis. Then monitor serum sodium changes every 1 to 4 hours depending upon symptom severity. All right, so if we are giving sodium correction to the patient, it is very important to check the serum sodium concentration every 1 to 4 hours depending upon the symptom severity. All right, because otherwise it may lead into the hypernatremia stage, or patient may develop hypernatremia. So these all are the points to be kept in mind in case of 3% normal saline infusion. Then the complication of infusing this or correcting this sodium rapidly can be osmotic demyelination syndrome, as I have already discussed about this. Then hypokalemia can be there, hyperchloremic acidosis can be there, hypernatremia. If more of this 3% NS has been given, that time patient may have hypernatremia. Heart failure can be there because patient may get into the fluid overload, as there is a risk of intravascular fluid overload. Then hypotension can also be there. All right, so these all are the complication of this what we say um, rapidly treating hyponatremia. And if we talk about this osmotic demyelination syndrome a bit, this is also known as central pontine myelinolysis. All right, myelinolysis. This is another name for osmotic demyelination syndrome, that is central pontine myelinosis. So this what happened, that this is actually a neurological condition that happens in pons area of the brain, and there is like a rapid increase of sodium to and the rapid increase, they damage the nerve cells. All right. So the symptoms may range from encephalopathy, or there may be pseudobulbar palsy, and the patient may also get paralysis and some extra pyramidal symptoms. Now we will talk about hypernatremia. In hypernatremia, as the name is depicting, hypernatremia, that is hyper is more, natremia is sodium. So the sodium level would be more than 145. That normal was 135 to 145. Less than 135 is hyponatremia, more than 145 is hyponatremia. Hypertonic state resulting in cellular dehydration. So the hypertonic state will this state would be result in cellular dehydration. So the person with the hyponatremia will have cellular dehydration, and commonly it is observed in patients without thirst response, high mortality rates if serum sodium more than 160. That so if the patient, this hypernatremia is not being treated and serum sodium goes for more than 160 milliequivalent per deciliters, there is high chances of mortality and it may be really fatal. So if we talk about sign and symptoms of hyponatremia, it is thirst, dry mucous membrane, decreased skin texture, acute weight loss. Patient will also have weight loss. Then weakness would be there, like body weakness would be there. Malaise can also be there. Restlessness, patient will be very much irritable in case of hypernatremia, and confusion would be there, hallucinations would be there. The patient may get ICH, that is intracranial hemorrhage, and sometimes coma, seizures and death. All right. So these all are the symptoms of hypernatremia. So if we talk about this treatment of hypernatremia, actually we need to treat the cause. All right, it depends upon cause. 2 liter water or too much sodium. We actually need to assess what is the cause. I mean, either there may be too much sodium, or sometimes there is less water, like there is fluid loss, the way water is very less, so the plasma sodium concentration increases, that time there would be hypernatremia. So we need to see, if the water is less, we need to resuscitate the patient accordingly with fluid, and if there is too much sodium, we will correct it accordingly. So the rapid correction is not indicated, either it is hyponatremia or hypernatremia. There should not be rapid correction, all right, because it results in cerebral edema, seizures and neurological damage and even death. So rapid correction is not at all indicated, neither in hyponatremia nor in hypernatremia. Then do not exceed a change of greater than 10 milliequivalents per day. So if we are treating hyponatremia, it is advised to do not exceed for more than 10 milliequivalent in 24 hours. Okay. And then we will talk about potassium, that is one of the most important electrolyte of intracellular fluid. The normal range is 3.5 to 5. In some books it would be written as 5.1, in some 5.2, so we can consider any. Then intracellular, it is intercellular cation, most abundant cation in the body. 98% is present in intracellular compartment and only 2% is present in extracellular. All right. Role of potassium in body is cellular synthesis and metabolism. Then this helps in metabolism and synthesis of the cellular activities. Then axial potential across cell membranes. It helps to generate action potential across cell membrane with help of this ATPase pumps, the neuromuscular activity and cardiac conduction. This potassium has a very important role in cardiac activity. All right. Then first we will discuss about hypokalemia. Then we would be moving towards hyperkalemia. Hypokalemia is potassium less than 3.5 milliequivalent per liter, but it is further divided as mild, moderate and severe. Mild is 3 to 3.5 milliequivalent per liter, moderate is 2.5 to 3 milliequivalent per liter, sorry, per deciliter. Then this is actually liter, not deciliter. All right, I'm sorry for the mistake. Then severe is less than 2.5 milliequivalents per liter. So this is the classification of hypokalemia, that is mild, moderate and severe. Mild is 3 to 3.5, moderate is 2.5 to 3 and severe is less than 2.5. Then if we talk about causes of hypokalemia, there is one causes, there is some GI loss like vomiting, patient is having rapid vomiting. Then few medications, um, we can say diuretics, because many diuretics are potassium, they do not spare the potassium, so there would be potassium would be lost. Then metabolic acidosis in that case. Then hypomagnesemia. Then sign and symptoms is, in case of mild it would be in this mild hypokalemia it would be asymptomatic, but in moderate to severe there would be severe muscle weakness, cramping, ileus would be there. Then ECG changes and cardiac arrhythmias would be there, and if it is not treated it may be life threatening. All right, because there would be fatal cardiac arrhythmias like ventricular defibrillation or ventricular tachycardia. Then hypokalemia treatment, we would be discussing the treatment of hypokalemia. So if potassium level is between 3.5 to 4, so if it is between 3.5 to 4, we will increase dietary intake of potassium rich food. Okay, we will tell patient to increase dietary intake, for example bananas, and we can say coconut water. So these are the foods which are rich in potassium. Okay, so in case of this mild, I mean 3 point, if potassium level is between 3.5 to 4, we will tell patient to increase dietary intake. Another example for potassium rich fluid can be broccoli, I'm sorry, broccoli, then potatoes, avocado and some beans and lentils. So these all are rich in lentils. So these all are rich in potassium. Then if potassium level is 3 to 3.5, we will start with potassium supplementation in patients with cardiac condition around digoxin. So usually we will start with potassium supplementation. For example, the syrup syrup Portchlor, we would start that, especially in patients who are having cardiac condition, because they are already at a risk of cardiac arrhythmias, or the patient on digoxin, because if the patient is on digoxin therapy and then potassium is less, the patient may develop digoxin toxicity. So it's very important to treat hypokalemia. Then we'll be discussing this chart. Serum potassium concentration, if it's between 2.5 to 3.4, we will be giving IV potassium replacement dosage, like that is 20 to 40 milliequivalents. Rate of infusion would be 10 to 20 milliequivalents potassium per hour, maximum of 40 milliequivalent potassium per hour. All right, so we need to give it slowly, and maximum concentration would be 80 milliequivalent via peripheral vein and 120 milliequivalent via central vein. All right. So we admixed it with 0.9% normal saline or 0.45% normal fluoride in water. We will use only these solution, 0.9% sodium chloride or 0.4% sodium chloride in water. So next, if serum concentration is less than 2.5, symptomatic, and it is symptomatic like severe symptomatic hypokalemia, we will treat with replacement dose of 40 to 80 milliequivalents in one go. All right. Mm, in patients with normal renal function or patients with the this correction is in patients with normal renal function, all right, but this one is in patients with renal insufficiency. I mean, if the patient is having renal insufficiency, already patient will have anuria and decreased urine output, and then he may already have risk of this potassium retention. So in that we will give very slow correction, that is 10 to 20 milliequivalents, and this is the maximum concentration. They should actually like the patient who is having renal insufficiency, they should receive 40 to 50% less of the initial empiric dose, and continuous cardiac monitoring and infusion via a central venous catheter are recommended for infusion rate more than 10 milliequivalents per liter. So usually 10 milliequivalent potassium per hour is given, but if it is given more, so we need to do continuous cardiac monitoring uh, if it is more than this, because there is risk of developing cardiac arrhythmias. So there are guidelines for administration of potassium. The potassium is never given in IV push. If it is pushed IV, it will definitely prove into a fatal situation. So this is always diluted and given in infusion. So we do not give more than 120 milliequivalents in 24 hours without ICU monitoring. If we are giving for more than 120 milliequivalents, the patient needs to be in ICU setting and need to be monitored very critically. Then potassium chloride is compatible with most of IV solution. Never administer concentrated potassium without first diluting. First we need to concentrate, only then we will first we need to dilute, only then we will give potassium. We will never give concentrated solution. Then potassium solutions is commonly used strength is 20 to 40 milliequivalents available in premixed form from manufacturers, and preparations greater than 60 milliequivalent should not be given in peripheral vein because it has risk of developing phlebitis. Alright, so usually if we are giving for more than 60 milliequivalents, we would not give in peripheral vein. Always central venous excess would be taken. Then make sure this potassium chloride mixes with the solution thoroughly. Invert and agitate the container because concentrated potassium can be lethal. Then do not add KCl to a hanging container. We need to prepare and invert and agitate the container. We will never add it to hanging container. Administer potassium at a rate not exceeded for more than 10 to 20 milliequivalents per hour. Then for extreme hypokalemia, rate should not be more than 40 milliequivalent while ECG is monitored. So maximum is 40 milliequivalent per hour, but we need to monitor ECG continuously. Then KCl administered into subcutaneous tissue infiltrated is extremely irritated and can cause tissue damage. Use extravasation protocol. So in case of potassium, we need to be very vigilant about phlebitis and extravasation. So we need to follow the protocol. Then use infusion pump to control flow rate. That is very important. Then use extreme caution for early replacement of potassium by secondary infusion. Potassium is primarily excreted through kidneys. Check kidney function test. So whenever potassium is being replaced, we need to check the renal function test, and if the patient has impaired renal function, we will adjust the dose accordingly. So these needs to be remembered while administering potassium intravenously. Now hyperkalemia, potassium level is more than 5.5. Then it is further divided into mild, moderate and severe. Mild is 5.5 to 6, moderate is 6.1 to 6.9, then severe is more than 7. milliequivalent per liter. Actually, hyperkalemia is very serious condition and it would lead to cardiac arrhythmias, which are actually lethal. So the causes of hyperkalemia is renal failure, mm, acidosis or red cell hemolysis that would result in accumulation of potassium. Then overcorrection is there, or medication. There are few medication which cause which spare potassium. There are many potassium sparing diuretics which cause hyperkalemia. Then salt substitute, traumatic injury, and adrenal insufficiency. So these all are the causes of hyperkalemia. So now we will be moving ahead towards sign and symptoms. Mm, so there would be ECG changes. This is very important to be noticed. There would be ECG changes, that is peak T wave. The the T wave would be peak in case of hyperkalemia, and depressed ST segment. ST segment would be depressed. Then disappearance of P wave and the QRS complex would be widened. All right. So peak T wave would be peak, ST segment would be depressed, and P wave may disappear with widening of QRS complex. All right. So this is very important. You need to remember this ECG changes in case of hyperkalemia. All right. Then the other symptoms are muscle weakness, paresthesia, GI hypermotility can be there, and sometimes paralysis. All right. So a normal ECG looks like this. I will show you. Okay. This is P wave, Q, R, S. Okay. So and this is T wave and presence of sometimes U wave. But in case of first we will see hyperkalemia, that is more potassium. So in this there would be flat P wave, as we have seen, as we have discussed, either flat or disappeared P wave. Then T wave would be peak. Wait, I'm so sorry. The P wave would be flat, then QRS would be wide. All right, it would be wide. Then the T wave would be peak, like this. The patient who is, and the ST segment would be depressed. All right. So the patient who is having severe hyperkalemia, his ECG would look like this. See, P wave is depressed, QRS is wide. All right, and T wave is peak. This is peak T wave, and this is widened QRS complex. And similarly, if we talk about hypokalemia, there are ECG changes. In hyperkalemia, what happened is P wave will be slightly peaked, like this. It would be slightly peaked and slightly prolonged PR interval, and there would be no changes in QRS. All right, but there would be ST depression. There would be ST depression like this. I'm sorry for this. ST depression like this would be there, and the T wave would be shallow. It would be very shallow. All right, very shallow, and but the U wave would be prominent. All right. The P wave in hypokalemia, what we say, there would be slightly peak P wave. All right. Then slightly prolonged PR interval would be there, and there would be ST depression here like this. There would be ST depression, and the T wave would be very shallow, but shallow T wave, but there would be prominent U wave in case of hypokalemia. All right, prominent U wave. So next we would be discussing about the treatment of hyperkalemia. Goals are reverse cardiac effect immediately, redistribute potassium from extracellular space into the cell, as there is more in flow this potassium we would redistribute from extracellular into the cell, then eliminate potassium from the body. Additionally, we will treat the underlying cause and stop excess intake of medication. Alright, so we will see the cause and we will treat it. Then treatment includes calcium gluconate, insulin and glucose. Like in clinical setup, we will use D25 100 ml with 10 units of normal human insulin, regular insulin. Alright. Then beta 2 agonist is used, sodium bicarbonate, sodium polycystine sulfonate tablets are used, then loop diuretics, and in worst scenario when hyperkalemia is not being treated with these medication, the patient will be taken for dialysis. Then magnesium, that is normal range of magnesium is 1.5 to 2.2 milliequivalents per liter. Then role in body, we will talk about the role of magnesium in body. Intracellular ion predominantly, this is predominantly intracellular ion, and if in found in bones and muscles. All right, this is written by mistake. So it is mainly found in bones and muscles. So next we would be talking about hypomagnesemia, that is decreased um, that would be decreased magnesium, that is less than 1.5. So the causes of hypomagnesemia is reduced intake, either the intake of magnesium is less, or absorption intake is adequate but absorption is less, or there is increased loss, either it is drug induced or often due to other electrolyte abnormalities, sometimes due to another, like secondary to another electrolyte abnormalities, hypomagnesemia may occur. Then sign and symptom is neuromuscular sign and symptom is patient will have tremor, hyperactive reflexes, and sometimes seizures. And in cardiac, there would be arrhythmias. Magnesium is like in cardiac patients, there may be depletion of magnesium, so it needs to be treated accordingly. And arrhythmias are quite fatal, like there may be ventricular fibrillation due to absence of uh, um, adequate level of magnesium. Like in case of hypomagnesemia, patient may develop ventricular tachycardia or ventricular fibrillation, or sometimes torsades de pointes. Then hypomagnesemia treatment is we can give either peroral or sometime IV infusion or IM. Alright. So in case of peroral treatment, we will give magnesium containing antacids or laxative, and magnesium oxide is being given, but there is side effect, that is diarrhea. So oral magnesium intake or magnesium supplements intake causes diarrhea. And moving ahead towards the IV infusion, we will give magnesium sulfate, and dose actually depends upon the depletion. Usually 8 to 12 gram is given, but if we talk about clinical settings, usually in one go, I mean in one dose, we usually give we usually prefer to give 1 to 2 gram of magnesium. 1 gram of magnesium actually have 4 milliequivalents. All right. So 1 gram of magnesium is 4 milliequivalents. So in one go, we usually prefer to give 8 milliequivalents of magnesium. Then standard infusion rate is 1 to 2 grams per hour. Alright. So that is like 4 to 8 milliequivalents per hour of magnesium needs to be replaced in a patient with hypomagnesemia. Then if we talk about hypermagnesemia, that is increased magnesium levels that more than 2.2 milliequivalent per liter. Causes are renal failure, acute versus chronic. Any kind of renal failure would lead to hypermagnesemia. And in elderly patient, adrenal insufficiency or hypothyroidism. Now the sign and symptoms of hypermagnesemia is usually, if it is less than 4 milliequivalents, it is asymptomatic, but if it is more than 4 milliequivalent, hypermagnesemia becomes symptomatic, and it includes weakness, nausea, vomiting, hypotension, respiratory depression, muscle paralysis, coma, and cardiac arrhythmias. So these all are the sign and symptoms of hypermagnesemia. All right. So there are ECG changes in hypermagnesemia, which are we can say the P wave would be flat and wide QRS complex, prolonged PR interval, and the last one was tall T wave. All right. So these are the ECG changes if the patient developed hypermagnesemia. So the ECG would look like, I mean, this is flat P wave, but the PR interval is increased. Then QRS complex is widened. All right. Then it would be like this, but the T wave would be peak, like this. So the ECG would somewhat look like this. The patient who is having hypermagnesemia, the ECG would be like this. All right. So the treatment includes reducing magnesium intake, then enhancing magnesium excretion. So either we need to reduce the intake or enhance excretion. Then drugs includes loop diuretics, like that antagonize physiological effect of magnesium, and IV calcium to antagonize neurological and cardiovascular effects of magnesium. As the patient with the patient with the hypermagnesemia usually is at risk of developing cardiac arrhythmia. So to antagonize that effect, usually calcium gluconate is given intravenously to the patient. Now the disorders of phosphorus. So the normal range of phosphorus is 2.5 to 4.5 milligram per deciliter. And if we talk about role of phosphorus in body, it is intracellular ion. All right. Then cell membrane function, it helps in cell membrane functions, DNA, RNA, protein synthesis, part of energy molecule, that is ATP, RBC function, and bone mineral. All right. So phosphorus is a bone mineral. Hypophosphatemia, that is less than 2.6, causes a decreased GI absorption. Either the absorption is decreased or increased urinary excretion of phosphorus and redistribution. So if we talk about sign and symptoms, basically we will understand this under subheadings like neurological, musculoskeletal, cardiopulmonary, and hematology. So in neurological, patient will be irritable, he may develop neuropathy, seizures, and sometimes coma. Then in musculoskeletal, patient will be having weakness, atrophy, rickets, and osteomalacia. In cardiopulmonary, patient will develop heart failure and respiratory failure. In hematologic, patient will have hemolysis, anemia, and hypophosphatemia. All right. So the patient will have this, I'm sorry for this is written by mistake. So in hematological, patient will have hemolysis and anemia. All right. So the treatment is mild to moderate hypophosphatemia. It is usually asymptomatic, and peroral phosphorus replacement in case of mild to moderate. But if it is severe, we need to treat it with intravenous phosphorus, that is 15 to 30 millimoles. That is usually 0.5 to 0.75 millimole per kg of body weight, total body weight. All right, this is total body weight. So maximum IV rate is 7.5 millimole per hour. This is maximum IV rate, that is 7.5 millimole per hour. So we need to monitor this 6th hourly. If we are treating intravenously, we need to monitor the this levels, phosphorus levels, every 6th hourly up to 72 hours of infusion. All right. So hyperphosphatemia, that is phosphorus more than 4.5 milligram per deciliter. So the main cause of this is chronic kidney disease or hypoparathyroidism. So these two are the main causes of hyperphosphatemia, that is chronic kidney disease or hypoparathyroidism. Sign and symptoms include, generally it is asymptomatic, but sometimes it may have hypocalcemia, ECG changes are there, and paresthesia can occur. All right. So in this hyperphosphatemia, hypocalcemia would occur whenever this phosphorus levels increase, calcium levels decrease inside the body. All right. So you whenever there would be hyperphosphatemia, the patient will have hypocalcemia, and sometimes paresthesia can also be there, and there are few ECG changes. All right. So one second. So if we talk about treatment, in treatment, um, we will limit the intake of phosphorus. All right. And phosphate binding agents we will give, so that it can bind and can be excreted out of the body. Then in severe cases, dialysis would be required, and replace calcium if patient is also hypocalcemic. Usually the when the phosphorus is less, the patient will be having this hypocalcemia, so we need to replace calcium accordingly. All right. So moving ahead, this is the last one, that is the disorders of calcium. So first we need to understand the normal range of this calcium, that is 8.5 to 10.5 milliequivalents per deciliter. And if we talk about ionized calcium, it is 1.1 to 1.3 millimoles per liter. All right. So these are the normal values and needs to be remembered. All right. That is very important. So first we would be discussing hypocalcemia, uh, that is decreased calcium inside the body. So first, we will discuss the definition. All right. So the definition of hypocalcemia is mild hypocalcemia. It is divided into mild and severe. Mild is total calcium less than 8.5 milligram per deciliter, or ionized calcium less than 4.65 milligram per deciliter. But in severe hypocalcemia, total calcium is less than equal to 7.5 milligram per deciliter, and ionized is less than 3.6 milligram per deciliter. And another classification is factitious, that is decreased total calcium with normal ionized calcium, that is asymptomatic. So if we talk about hypocalcemia, that is decreased calcium, there is three types. All right. That is mild, severe, and factitious. So in mild, total serum calcium, and this one is ionized calcium. All right. Total serum calcium would be less than 8.5, and ionized would be less than 4.65. And in severe hypocalcemia, this total serum calcium would be less than, I'm sorry, would be less than equal to 7.5, but the total calcium would be this total sorry the ionized calcium would be uh, less than 3.6. all right. But in factitious, what happened is the total calcium would be decreased, but the normal this ionized calcium would be normal. So this is factitious. all right. Etiology, if we talk about etiology of this hypocalcemia, this is with low parathyroid hormone, that is in hypoparathyroidism. Then with high parathyroid hormone, vitamin D deficiency is there, CKD is there, that is chronic kidney disease, acute pancreatitis, hyperphosphatemia, and other is medication, loop diuretics, multiple blood transfusion, or hypomagnesemia. So these all are the etiology of hypocalcemia. And before discussing diagnosis and treatment, we will be discussing the sign and symptoms. So there would be neurological signs, cardiovascular signs, and another chronic manifestations. If we talk about neurological, patient would be having tetany. All right, like tetany is due to increased neuromuscular excitability, Then patient may have seizures sometimes. Then paresthesia, that is perioral paresthesia is there. Then spasms may be there, that is carpopedal spasm is there, and muscle cramps and stiffness, myalgia. So these all are neurological signs, neurological symptoms of what we say hypocalcemia. Then if we talk about cardiovascular, there would be arrhythmia, that is palpitations, irregular pulse, syncope can be there, uh, hypotension, congestive heart failure. Okay, so this chronic manifestations are psychiatric are one second. So the chronic includes psychiatric, that is anxiety and depression would be there. Neurological, pseudo tumor cerebri would be there. In ophthalmologic, we will see papilledema and cataract would be there. And in dental changes, patient will have altered morphology and sometimes enamel hypoplasia can be there. And this is important point, like symptoms of tetany like spasm, cramps and paresthesia are the most characteristic feature of hypocalcemia. So spasm, like tetany is most characteristic sign of hypocalcemia, and due to this there are two classical signs that is that occurs in hypocalcemia, that is Chopstick signs, that Chopstick sign, and another one is Troche sign. All right. Another one is Troche sign. All right. So what happens in this Chopstick sign is also known as Wish sign. All right. So it is like this is a sign of tetany. These two are sign of tetany seen in hypocalcemia, and these mainly due to abnormal reaction to the stimulation of like impulse. What happen in this Chopstick is like abnormal reaction to the stimulation of facial nerve. Whenever the facial nerve is tapped at the angle of jaw, the facial muscle on the same side of the face will contract for the moment due to hyper excitability of nerves. So what happened in this Chopstick, there would be whenever we tap the this like we tap the facial nerve at the angle of jaw, there would be like facial muscle twitching would be there on the same side. Okay. Then if we talk about Troche sign, it is induction of carpopedal spasm. This was of this we will say facial muscles twitching. Okay. And if we talk about Troche sign, it is like induction of carpopedal spasm. So how it is induced? It is induced by inflation of sphygmomanometer above the systolic blood pressure for 3 minutes. We will inflate the sphygmomanometer above the systolic blood pressure. Suppose patient's systolic is 120. So we will inflate it above that for 3 minutes. We will keep it inflated for 3 minutes. All right. So what happened is, like what would be the response? Carpopedal spasm would be like characterized by mainly four things. First would be I will write here, it first will be adduction of thumb. Okay, so the patient's thumb would be adduction of thumb, flexion of there would be next response would be flexion of metacarpopharyngeal joint, metacarpopharyngeal MTCRP joint. All right. Then another response would be extension of extension of intrapharyngeal joint and intrapharyngeal joint, and the last one would be flexion of wrist. flexion of wrist. So these four are the responses of carpopedal spasm, that is adduction of thumb. Next is flexion of metacarpophalangeal joint, then extension of intraphalangeal joint, and the last one is flexion of wrist. So these three are the signs of carpopedal spasm. So this is all about Chostic and Roche sign that is seen in hypocalcemia. Next, if we talk about diagnosis, serum total and ionized calcium would be evaluated. Then electrolytes and kidney function test would be seen. Sometimes ABG and VBG is done to evaluate the calcium concentration. Then serum intact, this PTH. And that is parathyroid hormone, and ECG changes would be there, that is prolonged QT interval. These ECG changes would be discussed in upcoming slides. Then treatment includes calcium supplementation and treatment of underlying condition. So whenever a patient will have hypocalcemia, we will treat the underlying cause and the calcium supplementation would be given. Next is hypocalcemia treatment. Acute hypocalcemia we will treat with IV calcium, that is calcium chloride or calcium gluconate. 200 or 300 mg of elemental calcium would be given. Alright. Then monitor calcium every 4 to 6 hours during IV therapy and will treat the underlying disorder. So in acute hypocalcemia we will be given 200 to 300 mg of elemental calcium and we need to monitor calcium every 4 to 6 hours during IV therapy. In case of chronic hypocalcemia, we will be treating it with oral supplements like oral calcium supplement and oral vitamin D supplements. Alright. So acute hypocalcemia would be treated with IV supplements and chronic would be treated with oral calcium supplementation and oral vitamin D supplementation. So I hope this treatment and this topic is clear, that is hypocalcemia. So now we would be moving ahead towards hypercalcemia. So in hypercalcemia is what happened is serum calcium is more than 10.5 milligram per deciliter and ionized calcium is more than 1.3 millimole per liter. This is very important values and you need to remember these. Alright. So, what happened in hypercalcemia? Uh, Basically, these are like signs and symptoms. In bones, there is abnormal bone remodeling and fracture risk. All right, like the calcium has been taken from the bone and accumulated in blood. So, in bone, there would be abnormal bone remodeling because there is no calcium or very less calcium inside the bone and there is risk of fracture. And if we talk about stone, there is increased risk of kidney stone as there is increased concentration of calcium inside the blood. Groans is abdominal cramping would be there, nausea would be there, ileus and constipation. Patient with hypercalcemia always complains about constipation. Then psychiatric overtones are patient would be lethargic, depressed mood would be there, patient will develop psychosis and cognitive dysfunction may also develop. Alright. So now we treat, if we talk about treatment of hypercalcemia, we will treat it with intravenous 0.9% normal saline. Alright, then bisphosphates are being given to inhibit calcium release from bones. Okay, bisphosphonates are given because it will stop the release of calcium from bone and hold calcium inside the bone. Then steroids are also given. Chronic granulomatous disease, if hypercalcemia occurs secondary to chronic granulomatous disease, that time we will give steroids. And calcitonin is also given, that will this calcitonin actually inhibits bone resorption. All right, inhibits bone resorption. Then if we talk about parathyroidectomy, for like we may take patient for parathyroidectomy in case patient is having hyperparathyroidism, because in that case patient will have excess of calcium in blood. That time we have no other option than parathyroidectomy. Then dialysis in severe hypercalcemia like more than 18 milligram per deciliter. In that cases we need to send patient for dialysis. All right, so we will be talking about ECG changes in case of calcium. So normal ECG looks like this, that is normal P wave, QRS and T. But in case of hypocalcemia, QT would be prolonged. This QT interval would be prolonged. Alright. But in hypercalcemia, there will be the shortening of ST segment. This one. The ST segment would be shortened. Alright. So this is very important to be remembered. And ECG changes is hypocalcemia. There would be prolonged QT interval, whereas in this if we talk about hypercalcemia, there would be shortening of ST segment, and this QT segment would also be shortened. All right, QT segment would also be shortened. Segment will also be short. All right. And in this hypocalcemia, interval ST interval is lengthened and QT is prolonged. All right. So this is about ECG changes in case of calcium imbalance. I hope this lecture is clear to you. Thank you for being so patient with me, and um, we will be uploading more lectures for your NCLEX examination, and also we will take multiple choice question classes. So please stay tuned. And in case you have any doubts, you can drop down comments. So thank you for the class.